Dear friends, welcome to this webinar on genetics and biochemical screening in FGR. As you know, FGR is always a burning problem for us. It's a day-to-day problem. And we decided to be a little bit specific and make ourselves understand a little more on genetics with FGR. And I have with my panel Dr. Chaitra from Lilacs, who's a clinical geneticist. And this is an attempt to have a group discussion where we can show some cases, discuss the genetic aspects of IUGR, and then throw open the audience. So although I'm a fetal medicine specialist, I do more of ultrasound. Chaitra is genetics, and we have tried to reverse the roles. I'm talking on genetics, and she's going to talk on biochemistry in an attempt to see where we fall short with each other, and so we can help each other. Now, if you can see that from time immemorial, people have studied fetal starvation, and this was one of the earliest studies done in 1989 on chordosynthesis and looking at the fetal nutrition. And when they found a hypoxic fetus, they could see these biochemical and endocrine changes. And it was then concluded at that point of time that birth asphyxia can precede labor and is not necessarily due to the process of birth. And this was a landmark discovery at that point of time, and which allowed us a good understanding that asphyxiating processes begin much earlier. But since then, the definition and detection of IUGR has been the most challenging problem in obstetrics. So both the definition and the detection has been challenging. So although we describe fetal growth restriction as the failure to achieve endorsed normal growth potential, what is normal growth potential for each individual fetus is at dispute at times. We do have this controversy of SGA versus FGR, and all small babies should be suspect and evaluated for FGR till we conclude that it is not FGR and it is SGA. So SGA is, of course, a small fetal size, depending on your unit's decision whether you want to take a higher sensitivity or lower sensitivity and more specificity. You take it below the 10th, 5th, or the 3rd centile from a population-based reference chart. And majority of these fetuses were considered to be healthy fetuses with lower risk of abnormal perinatal outcome. This is vis-a-vis fetal growth restriction, as we call it, where there is increased risk of adverse outcome. And so the same small fetus is now at increased risk for fetal growth, abnormal morbidity and mortality. And it may at times be more than the 10th centile, so not meeting the lower growth potential, and this may remain undiagnosed. A sequential ultrasound scan is important to look at declining and crossing growth centiles, as we have seen in the Delphia consensus. And of course, functional parameters like Doppler, especially the umbilical artery, middle cerebral artery, ductus venosus, uterine arteries, these are important functional parameters, and also serum biomarkers, as Chaitra will elucidate. As we know, the most important accurate criteria for dating has always been the CRL, and after 14 weeks is the BPD, or the head circumference as we now consider it. And you can see a growth delay in a chromosomally abnormal fetus even in the first trimester, especially in trisomy 18, triploidy 13, and Turner's, not so much for Down syndrome. But you can also, more than seeing these altered CRL, you can also see body disproportions, which can be a very early marker for a genetic abnormality. So here we have a twin pregnancy, and normally, as we see, the abdomen is usually the same size of the fetal head, but in this fetus, you have a very thin abdomen here in the longitudinal diameter, and this could be due to triploidy and trisomy 18, and in this particular case was due to triploidy. It was an IVF pregnancy, twin pregnancy. Then Stuart Campbell brought about this excellent paper on looking at uterine artery Doppler, and since then a lot of work has been done. This was about 36 years ago, where he looked at placental changes in the first trimester, and any fetus with a high resistance uterine artery, as you see here, compared to a low resistance uterine artery. And of course, if the maternal arterial mean arterial pressure is high and had prior risk, which is high, if it's high maternal age, a body mass index which is above 25, and of course the ethnicity, if it's a white mother, the obstetric history, if there is previous preeclampsia, nullipara, cigarette smoking, and of course uterine artery Doppler. So 36 years ago, he highlighted us to the fact that a majority of IUGR can be due to placental insufficiency, and therefore this is an important marker for looking at that particular cause of IUGR. And since then, we have been looking at a lot of risk factors. Of course, the history is very, very important. History of, as I said in the earlier slide, but when we're looking at genetics, we look at family history, we look at consanguinity, and we'll see a few clinical cases with Chaitra in the end. This is biochemistry, so there are important markers which can highlight us to the fact that the placenta is not doing well, and therefore this could be growth restriction in evolution. And then there is ultrasound, which highlights us to the fact that there is low growth, there is oligohydramnios, decreased movements, and of course, further evaluation can be done. So we have numerous methods for evaluating fetal growth, and fetal weight is by far the best single marker for telling us if the growth is not appropriate. And these are some of the growth parameters we look at, as we already do: femur length, abdomen circumference, head circumference, and we usually use the Hadlock chart, which has served us very well. We've got a lot of new population-based charts, the Fetal Medicine Foundation, the WHO chart, the Intergrowth charts, but you can see that the same fetus can be plus minus a lot of variations if we use these charts. So these are not yet up to the mark, and I think a lot of work yet needs to be done to have a customized chart. But it's important to pick up a small baby the moment you see a fetus is small. That is the first management tool that you have in your hand. So the moment you pick up a small baby, you're already avoiding a stillbirth or a failure of pregnancy by almost 50%. So you see here there is a drop in growth profile, and indicating that this is a small baby. And once you have a small baby, then you look at the environment. Here, of course, this fetus had a single umbilical artery, a very thin, poor-looking placenta, and a moribund fetus. But when we're talking about genetic abnormalities, usually we will not see this sequence of events. We may see a very bulky placenta. The placental volume can be measured with 3D imaging. We see a high volume placenta, and of course, the LICA may be disproportionately higher than what we would see in a conventional placental cause for IUGR. The moment you have less LICA, also we could be dealing with, of course, renal abnormalities, which may be the cause of oligohydramnios, and this needs to be ruled out as an initial sign. We then had color Doppler, and color Doppler, as you can see, has again stood its test of time over the years. Just by looking at absent and reverse diastolic flow, you can see that 50% of perinatal mortality can be reduced, and therefore color Doppler, we know, is here to stay. We have now completely evaluated the role of color Doppler, and I'm not going to go into this because we are not going to talk about management of placental insufficiency in this particular talk. We are going to be doing a series of talks on growth in the coming weekend and coming week, and we're going to cover different aspects in different web seminars. So when we look at a small fetus, you know that this could be due to placental insufficiency. It could be a constitutionally small fetus, as you can see here. It could be dealing with infection. It could be a hormonal problem. And finally, it could be a genetic problem, and this is the focus of our talk today. So we're not going to talk about all these other parameters. Now, when we look at growth, we know that this could be either placental growth problem, placental function problem. It could be due to maternal characteristics, or of course, a fetal problem. The placenta can also have some associated genetic issues like confined placental mosaicism, and of course epigenetics alters the placental function. Essentially, when we are dealing with a chromosomal abnormality or fetal genetic disease, That's particularly the cause of a fetal cause of growth restriction. It could be a chromosomal, structural, or numerical abnormality. It could be a deletion or a duplication, a single gene disorder, could be epigenetics again, could be uniparental disomy, and of course, infections we will not talk about. And there are extrinsic maternal factors, which again, we will not talk about in this particular talk. So who is at risk for genetic abnormalities when we're talking about fetal growth restriction as a genetic cause? Of course, if it's an early to mid fetal growth restriction, if there is inappropriate liker and environment, there are structural aberrations or dysmorphology profile that you will see on the ultrasound. And this is what we'll try and focus on on this talk. And of course, there's biochemistry. It could be low PAPA at ADAM12s and low AFP as a marker for placental cause for fetal dysfunction, fetal genetic cause of growth restriction. When we are doing an ultrasound, we of course expected to do a complete morphology scan to look at all the limbs, to look at the heart, the head shape and size, to look at the facial profile. The limbs are very, very important because we can see a lot of markers in the form of the altered structure of the limbs. And of course, fetal tone and movements also elucidates us to the fact that there is something wrong in this pregnancy. So I have put down a list of markers that we should be looking at, and this is what I call a dysmorphology profile when we are dealing with early onset FGR. So you should be looking at the cranium skull shape because there could be alteration of the skull shape. You could see in the frontal view the orbits. You could have hypo and hypertelorism. You can have change in the orbital size. You could have change in the lips and the mouths. You could have a cleft lip, etc. You look at the profile, look at the forehead, the nasal bridge, the chin, ears, and look at the extremities for contractures, positioning of the limbs for webbing and syndactyly, look at the number of digits for polydactyly, and of course, other abnormalities with the digits. Look for other issues like hydrops and ascites. Genitalia, we are not supposed to talk about, but that's a very important marker when you're looking for fetal growth restriction, because you know that even if it is isolated, you can have hypospadiasis associated with fetal growth restriction. Therefore, you need to look at the genitalia, although TCP/NDT does not permit us to do so. We look for cardiac problems, and of course, we look for movement and tone for any kind of moribund appearing fetus. A lot of soft tissue markers are looked at in the second trimester scan at 18-20 weeks. I'm not going to go into that because this is something that has been covered extensively in the past few weeks in a lot of webinars, except to say that probably these four markers, the nuchal edema, absent nasal bone, the ventriculomegaly, and the ARSA are the important markers which have a likelihood ratio of at least 4 and above, with 6 being for absent nasal bone, and these could be important markers to look for. Now, what's important is that when we're dealing with genetic issues at the 18 to 20 weeks, sometimes things may be very subtle. Now, you have this fetus which has a 1-week delay in growth. There's good liquor, good placenta, and there's only mild ventriculomegaly at 10 millimeters. Of course, we would offer a karyotype or a genetic evaluation, which the patient refused. At that point of time, it's a very early case. Of course, now the patients are more cooperative. The ventriculomegaly stayed as it is, but there was further cardiac defects seen in the form of VSD and further drop in fetal growth of about 2 weeks. And of course, here you see the lichens excessive. So this is a classical case where we could be expecting a genetic abnormality as early as 18 to 20 weeks. At times, things may manifest very late. This is about 32 weeks with the 2-week growth lag. And here you don't see a fetal stomach. And again, you see polyhydramnios, and there is tracheoesophageal fistula that is suspect. So again, there could be a genetic issue. And this is a very unfortunate case where at 36 weeks, we were seeing a fetus, which is about IUGR with 33 weeks and with absent end diastolic flow, and all the tests done in the first and second trimester the anomaly scan and the combined screening were absolutely normal. There was no cardiac defect. All we could see was even, you could see oligohydramnios, a poorly looking placenta, absent in diastolic flow, and everything seemed like a placental insufficiency at this stage. The liver seemed a bit hypoechoic, and that was probably the only one feature which was a little unusual. And lo and behold, when this baby was born, it was a trisomy 21 fetus. So it just goes to show that, of course, we have false negatives in combined screening and all the other screening parameters, and sometimes we should be ready for surprises. Now, when we look at Doppler in genetic abnormalities, it's interesting to see that you could have discordant fetoplacental Doppler findings in FGR when you're dealing with genetic abnormalities. So trisomy 21 fetuses have a progressively higher incidence of abnormal umbilical artery indices throughout pregnancy. And you can see here, this fetus did show a high resistance pattern throughout. Alteration usually can begin in the mid-second trimester and increases with gestational age. And this is alluded to the fact that you could have significant reduction in small muscular artery count and compared to the Willis ratio, very similar to what you will see in preeclampsia. And this can be seen not only in trisomy 21, also in triploidy, trisomy 18, trisomy 13, and confined placental mosaicism. So it's a good idea to include Doppler. Of course, we always do it when the fetus is small, and to probably include Doppler as a normal parameter, as we would include with all screening, and that is something that one can discuss. But a lot of guidelines now do recommend prenatal genetic diagnostic test, FGR, and in FGR associated with structural abnormalities. Here you can see there's a bulky placenta, LICA is normal, but there are a lot of cysts in this fetus which had FGR, and we could be dealing with either a molar pregnancy or confined placental mosaicism. So when we look at chromosomal abnormalities in FGR, it's interesting to note that 19 to 20% of fetuses with FGR could be having an underlying chromosomal abnormality. And essentially, if you see this before 26 weeks, we have a higher chance of having a triploidy. If it's after 26 weeks, it is usually trisomy 18. So at times, a trisomy 18 may just not manifest in the 18 to 20 week scan, and it may be biochemistry which may lead you to doing evaluation if at all there is a high risk for trisomy 18. And overall, if you see it at all gestational ages, there is a 6% chance of having a chromosomal abnormality in a fetal growth restriction. Now, you could be having a varied list of genetic abnormalities when you're dealing with fetal growth restriction. So it's not usually the aneuploidies, which is highlighted here in red, which comes with high maternal age, but it's a lot of conditions which can happen to any woman at any age group. And these could be numerical abnormalities, structural numerical abnormalities. It could be mosaic pattern, confined placental mosaicism, and it could be deletions and duplications. So a lot of abnormalities. Now, this was a fetus with at about 23 weeks with this growth restriction and all the classical features of trisomy 18. So of course, if you see all these features, you know that the cause of growth restriction here is not a placental insufficiency, that's a strawberry shaped head. You are seeing a cardiac defect. There's of course gross Doppler changes here in disproportionate to the stage of growth restriction. So there's reversal, there's cardiac failure with a reversal of A wave, and of course the clincher is the overlapping fingers that you see here. You don't see a stomach, the stomach is small, there's esophageal atresia. So when we're dealing with growth restriction, it's usually the early growth restriction which has a higher incidence of chromosomal abnormalities. So in various studies, you can see here that before 24 to 26 weeks, the incidence of chromosomal abnormalities is higher, and after 26 to 28 weeks, the incidence of chromosomal abnormalities is less. And overall, it could be about 6%, and we'll talk about a microarray, which also adds about 5.5 to 6% over and above a chromosomal karyotype abnormality. Now, more severe, the fetus is small. So if you see here, if the fetus is on the 10th centile, 5th centile, and on the 3rd centile, higher the incidence of a chromosomal abnormality if it's a genetic etiology. So you can see here, it's 7.8% less than 10 centile, 10% less than 5 centile. And if it is a markedly growth restricted fetus, it's almost about 18 to 19%. Now, what do we do? What is the genetic algorithm? Of course, when we suspect an abnormality, we take a detailed history, look at family history, look at history of consanguinity, and then we offer a dysmorphology scan, as I just said. We offer genetic counseling. This is very, very important because there are at times details we may not pick up in a quick scan or in the rapid discussion that we have with the patient. And it's very important that the geneticist can counsel and find out a detailed history. And it's sometimes very remarkable that the patient has not told you something and it has told the geneticist, and you feel quite amused at that. And then you offer, of course, the appropriate testing. We usually begin with a rapid assessment, either a QF-PCR or a FISH for the usual aneuploidies. And if that is positive, then we move to a karyotyping to look for the parental status, whether it's a balanced translocation, which is causing that karyotype abnormality, to determine the recurrence risk. And of course, if the FISH is negative for an aneuploidy, then you quickly move to a microarray instead of going into a karyotype to look for a smaller structural abnormalities in the chromosome, which may not be picked up in the low resolution FISH and QF-PCR. And today we have beyond CMA a lot of gene panels which may be specific for growth abnormalities, and we'll talk about that, and even Chaitra can elucidate about that. So we have the skeletal dysplasia panel, we have the short stature panel, and then of course on the anvil, on the horizon, we have whole exome sequencing and the whole genome sequencing, which we have just started doing. So essentially at this stage, we would store the DNA, and if necessary, this may even be done at the pediatric stage sometimes. So when we are looking for aneuploidies, this is what we were looking for. But at about, I think, 2011, we were embarked upon a huge genetic journey where we could pick up many more genetic diseases with the advent of the microarray. And microarray is basically looking at the same structural and numerical abnormalities with a much higher magnification, almost 30 times as compared to a regular karyotyping. And at this point, I will just like to show one particular case here. This was of a fetus which was full term, symmetric growth restriction. This was a history given to us after the child came to us, after the parent came to us in the second pregnancy. And in the first pregnancy, I did not see them. This was and throughout the pregnancies, the Doppler was normal, the combined screening was normal. Of course, the only factor was that there was a growth restriction which was seen throughout the pregnancy. And at that point of time, when the baby was born, this was how the baby looked. Of course, looks grossly abnormal with a very pointed nose. There is incurving of the feet. There are very lax limbs, and there are delayed milestones. And the microarray showed some loss of about 382 kb at chromosome 20. Important thing was this, the clinical significance, if any, of the genes listed in this context of this patient's phenotype is unknown. So it did not match the phenotype of this fetus, and they had not done anything further evaluation. At this stage, probably what should have been done was a whole exome sequencing, and may have been done by now, and even a trio examination of the parents to look for any parental carrier status. So the important message here is that even when CMA did not find any pathogenic CNVs, syndromic phenotypes, either on ultrasound or on the pediatric age group, you can see after birth, and therefore a very close pediatric follow-up of an IUGR fetus is important to look for other abnormalities, which we shall allude to. Now, when we're talking about a microarray in a fetus with a normal karyotype, We all know that this is now proven its metal, and in about 5 to 6% of cases with a normal karyotype, we will see additional abnormalities on the microarray. And these are a large number of papers coming in almost every day in different journals. And you can see that if there is isolated FGR without any structural abnormalities seen on ultrasound, you could yet have about 5 to 6% additional information with the microarray, just with an FGR. Of course, if there are associated abnormalities seen with the FGR, your rate immediately jumps to about 10 to 15%. And overall, it is about, say, 6% overall. So there is a large variability of results, and this could be due to differences in the sizes of the studies, which needs to be looked into, the differences into the inclusion criteria, whether they were early IUGR, late IUGR, different interpretation criteria in the labs, and of course of the CNV pathogenicity. So there's, but overall, it's about 5 to 6%. Now, this is a particularly interesting paper published in 2019 on the role of microarray. And I like this paper because they studied about 162 IUGR fetuses. 78 had associated IUGR features. 84 had isolated IUGR. I'm sorry for the fine print, but I will just try and read out the gross details. So in both the groups, there was abnormal fish findings, both in isolated, it was less, about 5 had abnormal fish, and 10 in the associated group. So fish overall provided information about 8.6% of fetuses. Now, interestingly, in about 68% of the fetuses with normal fish, 6 showed abnormal karyotypes. So almost 10% of fetuses with abnormal fish showed abnormal karyotype. And overall, a chromosomal abnormality with karyotype was about 12.3%. Now, if we look at the normal fish and all the fetuses here again with normal fish, 6.1%, and of course karyotype, fetuses with normal karyotype, 6% showed abnormal microarray. So you can see the extent of abnormalities that can be seen with all the various genetic modalities when you're dealing with IUGR fetuses, either isolated or associated. So we need to review a lot of these cases to get a conclusive diagnosis. When we're talking of deletion defects, of course, as I've spoken in my earlier talks on genetics, the most common deletion is, of course, the DiGeorge syndrome. And you could have cardiac abnormalities, but not in all of them. The DiGeorge syndrome, of course, is also called the catch-22, 22q11 deletion. It is cardiac abnormalities, abnormal facies, thymic abnormality, hypoplasia, cleft palate, hypocalcemia, and that's the mnemonic. Statistically, most cases are sporadic and only about 8% are inherited. But what's most important is that a lot of these fetuses may just present with early growth restriction or nuchal edema in the early stages. And then, of course, they could have cardiac and facial abnormalities. So here you see that in these particular fetuses, of course, there is a bilateral cleft lip and there is a cardiac abnormality, which with a markedly hypoplastic, there's a phallostetrology with a small pulmonary artery, dilated aorta, and the thymus is hypoplastic. And this is another fetus at about 18 weeks with an absent pulmonary valve syndrome. And this could be, again, you see that the thymus is hypoplastic here. Now, the other deletion syndrome is, of course, the Williams-Buren syndrome, which is a 7q11 deletion. Again, multisystemic disorder, skeletal abnormalities, cardiac abnormalities in the form of supravalvular aortic stenosis. But a large percentage of these cases may not be picked up as a cardiac abnormality, but just as IUGR. And in this particular paper, which presented about 5 cases of antenatal detection of Williams-Buren syndrome, all of them had IUGR as the only finding, and at autopsy they found cardiac abnormalities. And you can see that there are some known names, Gangliopilu and other people in this particular paper. So IUGR can be one of the lead points in a lot of these syndromes. Here, of course, we are seeing a bicuspid aortic valve as compared to this fetus, which is showing the classical Mercedes-Benz sign, and which again was a microdeletion, William Bruins. And there is a aortic stenosis with supravalvular narrowing here, as you can see here. The other issue that we could be dealing with when we're dealing with a genetic issue is a mosaic pattern. And you know that when there are two or more different chromosomal complements in the fetoplacental unit from a single zygote, this is what we call the mosaic pattern, and this can be seen in about 1 to 2% of CVS samples. And we usually do an amniocentesis to then confirm whether it's a true mosaic or it's a confined placental mosaicism. And in this particular study by Grati et al., he saw that in about 1,500 cases of mosaics, true fetal mosaicism was seen in less than 13.5% patients. So most chromosomal mosaicisms will not present as an abnormal fetus, but they could present with fetal growth restriction, pregnancy loss, or perinatal demise in some cases. And when you look at that on the ultrasound, they could just present with a bulky placenta with multiple placental sonolucencies with or without hyperreflective border. So you know that when we're dealing with a molar pregnancy, you could have a hyperreflective border. There could be just areas of infarction or just a bulky placenta is what you may see. And when we analyze this placenta, you could be dealing with CPM for trisomy 2, 3, 7, 8, 9, 16, and 22, trisomy 7 being the most common. And of course, the differential diagnosis is a molar pregnancy where beta HCG levels will be high, and you would be dealing with the triploidy, and of course, a mesenchymal dysplasia where the AFP would be high with a normal karyotype. And a lot of these pregnancies studied in this particular case paper, as you can see here, presented with IUGR. So CPM presenting with IUGR is a very, very important factor. And at this point, I would like to consider trisomy 16, because that is also one of the important confined placental mosaic patterns that we would see. You could have a non-mosaic trisomy 16, which could lead to abnormal fetuses in the form of growth restriction, congenital heart defects, limb defects, and single umbilical artery. This could be the most common cause of the first trimester spontaneous abortion. It could be a confined placental mosaicism, which leading to IUGR in a structurally normal fetus. So this is important. The moment you see a CPM or if you see a bulky placenta, you need to offer a CVS, even if it's a structurally normal fetus. And it could be a uniparental disomy of maternal type. And these are some of the abnormalities that you can see. And in almost 50% of cases, you would be having a small for gestational age. And this is a whole spectrum of abnormalities that you will see with trisomy 16. This could be of uniparental inheritance, especially maternal, and again, when there is a rescue of the uniparental disomy, the trisomic fetuses, it could result in a normal fetus or a uniparental disomy, especially of 6, 7, 11, 14, 15, or 20, and this could lead to a lot of structural abnormalities and all presenting with growth restrictions. So you can see here a lot of syndromes dealing with 6, 7, 11, 14, 15, 20, and some of them are the Prader-Willi, the Angelman, the Silver-Russell syndrome, and there could be overgrowth disorders also. So the Beckwith-Widman is also a UPD11 with an overgrowth findings. The most common one being, of course, the Silver-Russell syndrome, and we'll talk about that. You could also be dealing with a monogenetic disorders, and here we have two groups of monogenetic disorders according to the body symmetry of smallness. And although we don't use the term symmetric and asymmetric IUGR, this is just to understand or further classify these fetuses, because we have some lovely flowcharts which can subclassify these two groups. So you have a symmetric smallness with additional findings, and you have asymmetric smallness with short, long bones, as you can see here, and these are probably all the skeletal dysplasias. So when we are dealing with a symmetric smallness, that is everything is small, we need to look for additional findings, genital abnormalities, as I said earlier, look for hypospadiasis or cryptorchidism, look for hand abnormalities, very, very important, look for syndactyly and clinodactyly and polydactyly. You could have specific signs for each syndrome as we have just seen, and you look for the head circumference. Is it a small head or a large head? So these are some of the limb markers. You could be dealing with talipus, you could be dealing with a rocco-bottom foot, a hallux valgus, and a separation here, and of course polydactyly. You could be dealing with hand abnormalities, and here the polydactyly and the syndactyly are of course important markers for a lot of syndromes, as you can see here. Trisomy 13, the ciliomyces, and the SLO you can see here. So a whole lot of list of syndromes which could deal with growth disorders. So it's very, very important that you look at the hand. And so the first group, where everything is small, you could have either genital abnormalities, or limb abnormalities, specific facial abnormalities, and they are classified in the form of if you have a relative macrocephaly or a larger head, the important one being a Silver-Russell syndrome, relative normocephaly, and there are a lot of syndromes which may not show up with typical findings antenatally other than just showing growth restriction. And of course, if there's microcephaly, you could have the Cornelia de Lange, the SLO syndrome, the Fanconi's anemia, and a lot of other syndromes, the Mayer-Gorlin syndrome, etc. Now, this is the typical appearance if you have an ambiguous genitalia with asymmetric growth of the limbs with a triangular large shaped head. So if you have a combination of these, you have short stature with asymmetric bones. You either have the long bones which are short unilaterally, and of course with ambiguous genitalia, with syndactyly, as I showed here. This could be, you could be dealing with the uniparental disomy leading to Silver-Russell syndrome. And you can see here one fetus here with asymmetric shortness of one of the legs here as compared to the other. So the moment you see these additional features, you know that you could be dealing with a genetic abnormality, and therefore you need to evaluate this further. This is another fetus with micrognathia, nuchal edema, and syndactyly, as you can see here. And here again, you could be dealing with a syndrome like the Silver-Russell syndrome or any other such combination. And there's another fetus here. So you could be having the Silver-Russell syndrome due to involving chromosome 7 and 11. Chromosome 7 is usually maternal UPD, and chromosome 11 is imprinted genes, and maybe we could be dealing with single gene defects. Here you have one of the most common ones being the Cornelia de Lange syndrome. And here again, you will have, like I said earlier, a microcephaly, so small head, but the characteristic features, of course, if you look for it, would be the prominent thick eyelashes, and which is associated with upper limb abnormalities. So this is very important when you look at growth restriction with a small head compared to Silver-Russell, which had a large head, and upper limb abnormalities. And of course, you could be having other abnormalities. And that is, of course, just showing normal eyelashes, and the high resolution ultrasound can today show you that, and you can see prominent eyelashes here. And this is all, again, asymmetric unilateral upper limb defects. You could be dealing with the Cornelia de Lange syndrome. You could be dealing with a combination of all these abnormalities, as I said earlier, with polydactyly, nuchal edema, and of course, low levels of estradiol, and that falls in place with the SLO syndrome or Smith-Lemli optic syndrome. Characteristic features again there. Now, this was a very early paper that we presented of a triphalangeal thumb. And again, here, this is a rare autosomal recessive disorder. And we can have upper limb abnormalities in the form of a triphalangeal thumb, and could have other abnormalities and again, growth restriction. Now, this was the same fetus that I showed you earlier on the microarray. We were We were seeing some deletions which were not phenotypically matching with this phenotype. But you can see that some of these appearances fit with what we call as the Mayer-Gorlin syndrome, which has a absent or small patella, short stature, and triad of microortia. You can see very small ears with a progressively enlarging prominent nose here, and you can see the lax limbs. And these are in having mutations in one of these 5 genes. Now here, of course, this child has not been evaluated. We think phenotypically this matches with this. And this, of course, brings us to the important fact that of the role of a geneticist, which can tell us which syndrome this can fit in. So you have a growth restricted fetus. This, as I showed you earlier, had growth restriction as the only phenotype seen on the antenatal ultrasound, and the microarray had not shown any major genetic loss. But we need to then further evaluate this fetus and do the parental evaluation to look for these abnormalities. Now, this was another fetus, 34 weeks, 30 weeks growth restriction. And you can see a host of abnormalities, renal abnormalities, single umbilical arteries. There is a hypotelorism. You can see that the eyes are small here. And this was a Treacher-Collins syndrome, which has a differential diagnosis with the acrofacial dysostosis, the Nagar syndrome or the Miller syndrome, and the other Goldenhar syndrome. And what we essentially see in these are a lot of host of abnormalities. So you see the limb abnormalities and the facial abnormalities. So there's micrognathia, there's a ear tag, and you can see upper limb abnormalities and small folded ears, as you can see classically in this fetus. This, of course, is not a representative fetus. This is the postmortem picture of this fetus, but just to show you a live patient with Treacher-Collins here. So these are the whole pictures, and moment you have these, you can then guide the geneticist as to this is what I'm thinking about in phenotypically, and then they can target their gene panel accordingly. Now, this is the second group of single gene defects. As I spoke to you earlier, the earlier one was symmetrically small fetuses. Here you have asymmetric smallness with the head not being as small as the other parts of the body. And so a few, of course, have a macrocephaly. You could be dealing with an achondroplasia, which is a late manifestation. If it's a normocephaly, this could be a Noonan syndrome. And if it's a microcephaly, this could be one of the rare dysplasias, skeletal dysplasias. So in this second group of syndromes, essentially we are dealing with skeletal dysplasias. I'm not going to go into a lot of detail on skeletal dysplasias because I'm doing a whole webinar on Sunday, which I invite you at 5 o'clock in the evening for skeletal dysplasias. Important to say that one of the most common abnormalities which can lead to a growth restriction is of course the Noonan syndrome, and we need to pick that up. We can pick it up even in the first trimester with gross nuchal edema more than 7 millimeters, and if the nuchal edema persists with the short stature and a femur length, and of course cardiac abnormalities in about 30% of the cases, we can be dealing with one of the rasopathies, as you call them, the group of disorders of the RAS mutagen activated protein kinase pathway. And these are the 4 genes that could be involved. And you can see here, this was a classical fetus that we had of persistent nuchal edema with small ears, very low set, and typical facial phenotype of a wide forehead, flared nostrils, and of course this was the PTPN11 gene involved heterozygous missense, which was a Noonan's. In this particular case, the cardiac structure was normal. So not in all fetuses will you have a cardiac abnormalities, and this can be explained by this chart. Cardiac abnormalities may manifest late. So in the first trimester, you will have nuchal edema. You could have agenesis of the ductus venosus. You could have then dysmorphic facial features, polyhydramnios, and then of course cardiac defects. And in not all cases will you have a cardiac defect presenting. So a genetic test, of course, is advised in the form of a Noonan's panel, and you may get a positive test rate of as low as about 20%. I may be corrected with Chaitra there's anything new in this finding. But if you have a constellation of these group of findings, you should suspect it, this condition. This is another condition where you could have a charge syndrome where there is retarded growth, polyhydramnios, again, genital abnormalities and ear abnormalities. You have a flat nasal profile. The olfactory sinus sulcus is not well developed. And of course, you have the coloboma, which you can see here, the prominent coloboma here, which can be seen even on 3D imaging. But important factors being that is a constellation of heart defects, the choanal atresia, retarded growth, and then of course you do the specific gene analysis. Again, skeletal dysplasias, as I said, you could have large head with small bones, typically thanatophoric dwarfism, the telephone receiver type. You have hypomineralization, osteogenesis imperfecta. You have chondrodysplasia punctata with the echogenic punctate epiphysis here. And of course, marked bowing with the campomelic dysplasia. And these are all the genetic associations. I'm skipping this because we are going to talk about it in on the Sunday. So the exome sequencing will yield, of course, a confirmed diagnosis in about more than 80% of these cases. And again, the ISWAG approach to skeletal dysplasias, I will not talk about it today, but it's a very good flow chart and we'll talk about it on Sunday. The fetal face can be a good marker when specifically when you're dealing with skeletal dysplasia. So that's nasal bridge depression or Binder's facies, as you could see with trisomy 21 and chondrodysplasia punctata. You could have frontal bossing with achondroplasia, and of course micrognathia with a lot of first arch syndromes, the Treacher-Collins and trisomy 18, and again cleft lip, cleft palate. Again, we'll talk about this on Sunday. As I've already spoken, you could have low set ears in Noonans, you could have folded ears in Treacher-Collins, and of course, structural abnormalities may lead to microaortia in this particular case. Here, I'd just like to highlight upon one case here. This fetus had microcephaly with short, long bones and a lot of facial dysmorphia. And this, of course, came to us at 35 weeks with a lot of exuberant bone formation. So normally when you deal with skeletal dysplasias, you either deal with hypomineralization, but this was exuberant bone here with some degree of fracturing there. But the important thing was there was gross facial dysmorphology, and of course this did not fit with any particular syndrome. So when we did a clinical exome, only then we could come to a final diagnosis of an osteosclerotic bone dysplasia, the Rain syndrome, which is having its locus on this 7p22.3 chromosome. So this just goes to show that genetics can give us a conclusive diagnosis for recurrence, to give us better counseling for the patient in these particular situations. And again, a whole group of abnormalities called the arthrogryposis or the fetal akinesia deformation syndromes, which can lead to growth restrictions with fixed flexures and contractures at the various limb. And there's a whole huge list of abnormalities that we could be dealing with. It can involve almost every system in the fetus. And again, we'll talk about this on Sunday. So the entire skeletal dysplasia group. It could involve only one extremity or may involve the entire fetus. This was an interesting fetus where we had fixed flexion of this limb, and there was fixed flexion of the foot here, and we thought we are dealing with a skeletal dysplasia, I mean an arthrogryposis, an distal arthrogryposis unilateral. But interestingly, sometimes you see surprises. This fetus had tied a knot to its limb here, and it caused ischemia of that limb. And you can see that it's not always distal arthrogryposis. So this is a rare differential diagnosis in this particular case. Here, of course, there were a lot of limb abnormalities, growth abnormalities, but you can see a lot of constriction abnormalities. And these were probably, you can see the bands which are stuck here. So just an amniotic rupture sequence leading to these findings. Now, a lot of people have been doing the whole exome sequencing also in the first trimester and coming up with different syndromes which could be dealing with short stature in the future. So we may not see the short stature because these fetuses would be terminated at this stage. And this was Katia Bilardo's series, which I just picked up. They had done a WES just due to a cardiac and nuchal edema, and they found a syndrome called Kabuki syndrome. And finally, to round up, they are very oftenly seen single umbilical artery that we see in almost about 2% of our pregnancies, 1 to 2%. We have conclusively seen in various meta-analysis now that there is no statistical significantly increased risk of aneuploidy, but you may have impaired growth, and therefore you need to follow up these fetuses, and this is definitely not an indication for invasive diagnosis. Now, this is a whole list of abnormalities that we could be dealing with when we're dealing with fetal growth restriction. You could have chromosomal abnormalities, deletions, monogenetic disorders, and the confined placental mosaicism. Of course, all this I have already spoken about in the preceding slides. Now, this was the dysmorphology slide that I showed earlier, that we need to look at every particular profile of this fetus, specifically when we're dealing with an early onset FGR, or if you're dealing with very low PAPE and low alpha fetoprotein, you need to evaluate these fetuses very carefully. I will stop at this point of time, and I will invite now Chaitra to further take this topic further, and then probably come back in the end for conclusive statements. So Chaitra, can you take over for the second part of this talk?
Sure, sir. Good evening to all of you. And thank you so much for attending this webinar. So thank you very much for such a detailed oriented presentation on the different types of syndromes that could be associated with FGR. So I'm going to be throwing some light on the biochemical screening and the different genetic tests that we can do in the area of fetal growth restriction. So if we move on to biochemical screening in the first trimester. So in the first trimester, basically the different screenings that can be performed to, to generate a risk assessment for preeclampsia is a combined first trimester screening with PLGF included in it, which is the 3-beta-LCG, PAPE, PLGF, along with the NT and uterine artery Doppler. The first trimester quadruple screening, which will include these 3 markers along with AFP. And then there is the preeclampsia screening, which is the PAPE plus PLGF plus uterine artery Doppler and mean arterial pressure. PAPE and PLGF being the most important biochemical markers, along with uterine artery Doppler and mean arterial pressure, and the preeclampsia history along with chronic hypertension. These are things which we should be keeping in mind in order to be able to generate a risk assessment for preeclampsia. If we see the detection rate and the management of the pregnancies, the detection rate is approximately about 90% when we include the mean arterial pressure, uterine artery, PI, PLGF, PAPE, and the history of chronic hypertension and preeclampsia. The risk assessment is divided into 2 categories. Either it is a high risk, or the result could be a low risk. If the risk assessment falls in the high risk category, then according to the ASPRE trials, prophylactically aspirin needs to be given 150 milligrams to all the patients. And this aspirin the administration of this aspirin needs to start before 16 weeks in the pregnancy. So if it is a high risk, then we need to monitor the risk for preeclampsia at 22 weeks. We move on to the second trimester screening for preeclampsia. There is a test called as the preeclampsia predictor, which is almost a diagnostic test in which the SFLT and PLGF ratio is looked for. Even if somebody has done a quadruple marker, the importance of looking at the moms, especially the free beta LCG, the inhibin A and the AFP moms, because a raised free beta LCG or a raised inhibin A or a very low AFP, these are all indicative of increased risk for placental insufficiency and fetal growth restriction. So if we look at the second trimester, the preeclampsia predictor almost has 100% detection rate for for the SFLT PLGF ratio along with the uterine artery PI and the mean arterial pressure. So if we do a preeclampsia assessment at 22 weeks, either they fall in the high risk category or they fall in the intermediate or the low risk category. And then there is a further management that needs to be done, because the pregnancy needs to be monitored serially for the growth, right from from the 22 weeks right up to 32 weeks. Now, what is this SFLT PLGF ratio, and what is it actually giving us? So the ratio of 38, the predictive value of 38 is considered as a cutoff for the SFLT PLGF. And the value of, if the value is lesser than 38, then it's angiogenic, and where we know that the vasculature is normal. If the SFLT PLGF ratio is, or the value is above 38, then we know that it is anti-angiogenic, and these values have a product, like, so the value of higher than 38, it has a positive predictive value of 36.7% for a diagnosis of preeclampsia within 4 weeks. So there's a very interesting article which is the predictive value of SFLT PLGF ratio in women with suspected preeclampsia, which you can go through, and that it has a very clear research done on the cutoff of 38, which is considered as the predictive value for SFLT PLGF ratio. The value of a lesser than 38, it has a NPV of 99.3% with a 80% sensitivity for to be able to do a risk assessment for preeclampsia. So if we move on to the core genetic disorders which could be causative of fetal growth restriction, there are different types of genetic disorders which could result in fetal growth restriction. There are chromosomal disorders. So if we look at this picture here, this is a picture of a cell. The nucleus contains all the chromosomes. So all the genetic material is present inside the nucleus of the cell. This genetic material is present in the form of chromosomes. And DNA is very, very tightly coiled to form chromosomes. So there are three kinds of disorders. There is chromosomal disorders, which sir has explained in detail in his presentation. There are monogenic disorders for which he has actually shown very clear pictures regarding what syndrome and what could be the phenotypic presentation of its syndrome, which are the single gene or the monogenic disorders. And then we have the polygenic disorders, which are or the multifactorial disorders. So if we look at fetal growth restriction, there are different kind of tests which can be considered for fetal growth restriction. There are different genetic tests. There's chromosomal karyotyping. There is microarrays. There are single gene disorders where we can do the exome panels or the different kind of NGS panels. Infection testing needs to be done in case of FGR through a torch PCR, or DNA storage if the patient doesn't want to opt for any test at that moment. However, when we look at this, there are so many different tests, and so many different tests, can create a sort of confusion depending on, what is the right diagnosis to offer for each patient. So what are the different points we need to keep in mind before we offer a test to the patient? First and most importantly, what is the indication exactly? Is it only IUGR, or are there any other ultrasound markers which are in combination with the IUGR that is being seen? So is there any other dysmorphology in the fetus? What is the family history? Is the couple, are the couple consanguineous or they're non-consanguineous? And if there is an availability of a genetic counselor or a clinical geneticist, please refer the patient so that we'll be able to understand what is the right test to be performed in this particular scenario. So I'll discuss a few cases now. So this is the first case of a non-consanguineous couple. First gravida, healthy male child. Second gravida, the ultrasound findings were suggestive of a small for gestation age fetus, hypoplastic nasal bone, and a thickened placenta. So this was the pedigree for the patient. They were a non-consanguineous couple, as I stated earlier. When they came in their first trimester first trimester screening, dual marker suggested that the PAPE values were 0.36. So very low PAPE of below 0.3 is suggestive of, or indicative of preeclampsia or IUGR. So there has to be a further evaluation done if the PAPE is less than 0.3, like 0.3 or less than 0.3. So over here, if you see the fetal growth restriction before 37 weeks had a risk of 1 in 88. There was, at that point, there was no, sort of analysis initially that was done. The patient was on aspirin. However, at the anomaly scan, when it was suggestive of these anomalies, the patient opted for termination of the pregnancy because they did not want to go ahead with the pregnancy. After the termination, the product of conception was sent for testing for microarray initially. The microarray findings were suggestive of an abnormal gain in chromosome 2. This gain in chromosome 2, technically it is noted to have flat facial profile. It is noted to have micrognathia. When we actually did a visual autopsy, so whenever we are doing whenever an MTP is done for a fetus post 16 weeks, it is very important, especially in cases of IUGR and IUFD. It's very, very important to take pictures of the fetus on the, with the correct profile, so that whatever genetic test we do, we can correlate it to a phenotype. If we, like Sir suggested in the Mayer-Gordon case, if the pictures of the fetus, whenever initially if the IGR was noted and they chose not to go ahead with the pregnancy, the microarray findings would have just been taken into consideration without, looking at the phenotype. In this case, because the phenotype is available and the child was born, we are able to tell that the microarray findings were not suggestive of this particular case. However, if in this case, if they had not gone ahead with the pregnancy, had they seen any ultrasound findings, then we would have probably misdiagnosed this case. So in order to not be able to misdiagnose cases like this, it's very important to do a visual or a fetal autopsy if you have a center available, and to do a genotypic correlation so that we are able to definitely diagnose what the syndrome is, in order to be able to give you a recurrence risk for the future pregnancies, because all of this diagnosis is done so that we can establish a recurrence risk in the future pregnancies. And that is why this autopsy becomes that much more important. In this case, the microarray findings could be correlated to the phenotype, and but this partially confirms a diagnosis. Until we do a parental analysis, we will not be able to establish the exact status of the variation. So parental testing after all these findings also is very, very important. If we move to the second case, this is a case of a consanguineous couple. The first pregnancy was terminated due to an anencephaly. Second pregnancy has a healthy child. The third pregnancy, there was an IUGR with an abnormally large kidney with an omphalocele. Now, in this case, if you see, the first trimester findings had a PAPE was again 0.291. So looking at the moms becomes that much more important in every test. This was also a second trimester anomaly scan, and they chose not to go ahead with the pregnancy. So in this case, now again, we are back to what test should be recommended in case of a consanguineous couple. But when we look at all these, sort of ultrasound abnormalities, it was sent to us for a microarray. When we did the microarray findings did not reveal any gain or loss. They revealed a loss of heterozygosity. In cases of consanguineous couples, it's very, very important to rule out autosomal recessive disorders. So based on the family history and the recurrence risk of the condition, or to determine the recurrence risk of the condition, we had to do a clinical exome on the product of conception. Fortunately, the parents also cooperated. We did a clinical exome, and there was a compound heterozygous mutation in the Meckel syndrome. Meckel syndrome is an autosomal recessive disorder. What we need to do in this case is we need to do a parental testing for the mother and the father, and we need to do a mutation specific testing for both these variations in the parents in order to be able to determine the recurrence risk. So in case one of the parents is a carrier for each of this mutation, then the recurrence risk in every pregnancy is 25%. Then in these cases, we can offer a pre-implantation genetic diagnosis if required, or we can offer prenatal diagnosis in every pregnancy. So depending on the parental testing, we can decide what the recurrence risk is going to be. just on the basis of the fetal testing, we'll not be able to determine the recurrence risk. And that is why testing the parents and the fetus is that much more important. If we move on to the next case, in this case, the first gravida had a severe IUGR, terminated. Second gravida, 5-year-old child, severe developmental delay with cleft lip, palate, and descended testes. Antenatally, this fetus had a IUGR and oligohydramnios. Now, they were currently pregnant at 14 weeks when they came in for a counseling. Based on the family history, we actually ordered a microarray, but because they were not very affording, they opted for a karyotype. Now, whenever we have a proband in genetics generally, whenever the index case is available or the proband is available, it is very, very important to first test the proband before testing anybody else. If they are not willing to test the proband, you have to explain and counsel to them that recurrence risk of any condition or identification of a genetic condition will only be able to ascertain once the proband is worked up. There are a lot of times that parents come in for counseling, or they may be coming whenever they come to you also, and they say that this child, whatever has happened, we are not able to change anything. So in these cases, we don't want to work up the child. You do whatever testing you want directly on the fetus. Even if we do, even if a procedure is done for the fetus and we have the CVS or the amnio, we don't know what we are going to look at. And even if we do a genetic test and we find a mutation, or we find, say, a deletion or a chromosomal variation, we don't know whether that is what was responsible for the phenotype of the earlier child. So workup of the index case is of utmost importance, and that is the primary workup that should be done. Fortunately, in this case, we had a couple of weeks, so we offered karyotyping or microarray. So they opted for karyotyping, like I said. So the affected child had a derivative 9. So it was a 46XY with a derivative 9. Derivative on chromosome 9 meant extra chromosomal material on chromosome 9, extra genetic material on chromosome 9. The first thing we did after this was the parental karyotype. The parental karyotype revealed that the father had a balanced translocation in chromosome 9, in between chromosome 9 and chromosome 13, which meant that there is a recurrence risk in every, in all future pregnancies. So either you can offer a microarray for them in all the future pregnancies, along with the karyotype, of course, or you can offer a pre-implantation genetic screening if they opt for IVF. But recurrence risk, like I'm going to reiterate this fact that index child analysis along with parental analysis is extremely important to diagnose or to complete the diagnosis of any genetic disorder in the family. So in this case, the prenatal karyotyping and microarray was advised because she was 14 weeks pregnant. This is another case of a primary gravida, consanguineous couple. Ultrasound was suggestive of IUGR microcephaly and hypoplastic nasal bone. There was no family history, we had nothing else to go back to. Microarray analysis revealed an LOH again. Because they had already opted for termination given the ultrasound findings, we had the DNA stored because the microarray was done. Since the microarray did not reveal any gain or loss, a clinical exome sequencing was advised on the POC DNA. In consanguineous couples, it's very important to rule out autosomal recessive disorders, like I said before. In this case, there was a homozygous mutation in ALG3 gene responsible for glycosylation disorder type 1D. So in this case also, luckily we had done a trio clinical exome, and we also understood that the mother and father were heterozygous carriers of the same mutation. So we know that the recurrence risk in every pregnancy is going to be 25%. Now this is the fifth case where it was a primary gravida, advanced maternal age, non-consanguineous couple. Ultrasound was suggestive. So first, actually, the test had come for a quadruple marker, or the patient sample had come for a quadruple marker. The quadruple marker had very low moms for beta LCG, only about 0.2. And non-consanguineous couple, the targeted scan then was done and it was suggestive of a cleft lip and palate. There was also mild IUGR. So in this case, we did a microarray and there was an abnormal loss on chromosome 4 responsible for Wolf-Rashon syndrome. This was a mosaic loss, so it was 71% mosaic loss for Wolf-Rashon. When we did the genotype-phenotype correlation, in about 25 to 50% of Wolfershon syndrome fetuses, cleft lip and palate is observed. So there was a clear-cut genotype-phenotype correlation. Parental karyotyping was established, was done to establish the recurrence, but it was normal. So there was, basically in every future pregnancy, we just need to do the prenatal diagnosis, and then we can take it forward from there. This is another case where the pretest counseling for a non-consanguineous couple, the ultrasound findings were suggestive of a bell-shaped thorax, short ribs, and shortening of bilateral long bones. Now, in this case, the main dilemma is whether to do a microarray or whether to do an NGS panel. Whenever we see a skeletal dysplasia, so skeletal dysplasias and renal disorders are more because of single gene disorders rather than microarray findings. So actually, this case had come in for a microarray into the lab, but we changed the test request after requesting the patient and the clinician to skeletal dysplasia panel, because in skeletal dysplasias, microarrays don't yield any positive, genetic findings. So when we did a skeletal dysplasia panel, there was a compound heterozygous mutation in the WDR34 gene, indicative of a short rib thoracic dysplasia type 11. And the post-test counseling involved suggesting the parents to do an evaluation by Sanger sequencing. So Sanger sequencing is done for mutation-specific testing. Once we identify a mutation in an NGS panel, we need to first confirm it with a Sanger, and the parental testing then is done through Sanger sequencing. So in this case, the parental evaluation was observed. The parents were heterozygous carriers, one each of each mutation, and which again, confirms that there's going to be a 25% recurrence risk in every pregnancy. So when we look at these cases, there is a wide array of, different types of genetic abnormalities. There were chromosomal abnormalities. There are, abnormalities related to skeletal dysplasia. There are other autosomal recessive disorder findings in consanguineous couples. So this actually there is an array of tests that can be offered. So this actually sums up what I was mentioning earlier, that looking at the indication, looking at the family history, understanding the history of consanguinity, and at least like a 2 or 3 generation family history if it's possible, that can help us determine what sort of a test should be offered to this patient. And a very, very thorough, very, very thorough ultrasound to understand whether the IUGR, whether there is only a fetus which is a small for gestational age, or is it actually associated with other ultrasound findings also? Because then that is going to change the test, that may change the test that should be offered to the patient. Like when I was talking about fetal autopsy, if the fetus is lesser than 20 weeks, it can be sent for an autopsy. If the fetus is more than 20 weeks, then we need to do a skeletal examination, and we need to take pictures of the fetus when the sample is sent for genetic testing, so that the genotype-phenotype correlation can be done very smoothly. And we can actually ascertain that the findings that we have found in the genetic testing are responsible for this particular phenotype. So that is how a genetic test actually completes the sort of circle. So unless we are provided the correct clinical diagnosis or the clinical findings, it's very difficult to suggest a genetic test. So the relationship of a consultant and a lab is a hand-to-hand sort of relationship. So that we are able to diagnose the disorder correctly on the basis of the findings that are given to us. So with this, I'd like to hand it over back to Sir, so that Sir can summarize the entire session. And then we can take questions after that. So, Sir, thank you so much, and over to you.
Thank you, Chaitra. I think very well you elucidated to the fact that good ultrasound and genetic and phenotypic correlations is very, very important, and these are some of the sound to give them a lead as to which genetic test to do. So here, of course, you can see that as Chaitra alluded, we have a lot of gene panels We have the attempt is here is to focus on a specific number of genes so that you don't waste too much time looking at a whole spectrum of genes and then get a lot of unwanted information. So once you have an ultrasound which guides us to which gene panel. So we have a short stature panel, skeletal dysplasia panel, the Noonan panel, and you have a lot of other information that is coming in. Now, just for our ultrasound, we have these 5 types of reports that may come in. There could be a pathogenic variant, a likely pathogenic variant, indicating that it matches with the phenotype that you see on the ultrasound. Then you have a likely benign pattern or a benign pattern of a report, as you saw in her cases, where the parents also had the similar deficiencies. So you need to then look at the parental genotype. And of course, sometimes we don't have a very big database in India yet. It could be of unknown significance. So you keep the pictures, you keep the DNA, and maybe later on, once the baby is born, you could then get further information from the information that you already have. Now, that's why if you saw all her cases, they were very carefully worked up, and it allowed you, it's very important to get a specific prenatal genetic diagnosis at most times, because if it is, of course, a major abnormality, allows us to terminate with the PCP-NDT rules or the MTP rules that we have to follow. But if otherwise, we can get better antenatal information for the parents to understand the outcome and the prognosis, especially regarding the probability of an intellectual disability. And you can also see that we can do a lot of recurrence risk counseling once we have the information from the genetic lab. So it's very important to have a good phenotype and genotype correlation, and not be always possible to do appropriate antenatal diagnosis, and therefore a pediatric follow-up after birth of an IUGR fetus is also important. So it's important to counsel your parents that look, there is IUGR, we have not come to a conclusive statement. If you have not found any placental insufficiency, so you need to be ready for some pediatric evaluation. Again, more and more antenatal therapy is being offered and will be offered in the future also. So a definitive diagnosis is very, very important. And you can see that some stem cell therapy for osteogenesis imperfecta is already being carried out in this study. And this will allow us to continue some of these pregnancies. Of course, you need to diagnose the condition with a genomic evaluation. She showed us that a trioexome is definitely a better way of looking at a targeted panel analysis, because it minimizes the risk of looking at additional findings. So you just focus on the parent's gene and you focus on the phenotype, and you can get the evaluation of the relevant genes. And you can make out from which parent it is inherited, and you can identify a recessive gene that predicts the parental phenotype. You may sometimes have the, like I said, if it's pathogenic, it may correlate to the ultrasound pictures or the phenotype postnatally. At other times, it may not correlate, but you need to keep the data as you may later counsel whether these can be of any importance of this fetus in the future. Because you may get sometimes unwanted information. There are, of course, limitations. It's a costly procedure at the moment, but in the last 10 years, we have seen the costs coming down drastically, and we can now offer it as a reality to the patients. Sometimes there can be difficulties in interpretation due to limit of advances in imaging. We may not see all the abnormalities. There could be limited coverage of the disease-causing genes, ethical issues around the identification of incidental findings. If you use a whole exome genome or whole exome sequencing, so there are some difficulties in interpretation. There are, of course, guidelines available in the pediatric age group, but not many guidelines are available for prenatal management. And this is, of course, ever expanding. So this is, again, a limitation for the time today. But what's most important is that prenatal imaging has a very big role to play today. And when you have a growth restricted fetus, we should not always think findings, advise invasive diagnosis, speak to the geneticist if you have a polydactyly syndactyly, or if you've got a polyhydramnios, if you've got a syndactyly, speak to the geneticist, try to identify whether it fits into any panel, whether it's a skeletal dysplasia panel, and you need to get good expertise, maximize the benefit of all the imaging and genetic modalities and that you have, and then only we can offer a definitive diagnosis. These are, of course, some databases which are available, not really important for us, but the geneticists allude to these quite often. And once again, I thank you for a very patient hearing. So I think we have finished our presentation now. And if there are any questions, Chaitra, we could answer them together.
Sure, sir. Sir, so we have a question that if there is a low risk by FTS or by NIPT, and later on there is a fetal growth restriction seen in the scan, should we counsel the patients for an invasive genetic test?
Yes, of course. Like I showed you, in many cases, we had low risk for combined screening, but later, so combined screening is only directed towards major aneuploidies like trisomy 21, and even the NIPT, of course, is very specific for, for trisomy 21. It does not tell us information at this point of time. Of course, in the future, you may come up with more information, as you are already coming up with extended gene panels on the NIPT, but these are not yet very well evaluated at the moment. So you do need to, if you have additional findings with the IUGR or it's early onset IUGR, I think you should offer genetic counseling and then offer an invasive diagnosis.
If we should offer testing, then should it be offered after 24 weeks, as we will be able to diagnose majority of the anomalies after that? If the patient agrees for the testing, what test should we do? A chromosomal analysis, an array, or an NGS?
Yeah, so that's a very, very extensive question, and I think the whole topic was covered in that
Yes.
I would say that many of the times you will pick up the phenotypic abnormalities in ultrasound even before 24 weeks. So it's not always that you will pick them up after 24 weeks. But let's look at two groups. Suppose you pick them up before 24 weeks, say like closer to 20 weeks, and definitely you offer them a genetic diagnosis and you find something abnormal. I think now we have a new ruling which permits an abortion even after 20 weeks. And so in specific situations, if it's a lethal abnormality, if it's a major genetic abnormality, I think not only 24, I would even extend it beyond 24 weeks. We would definitely order a genetic test after genetic counseling. Now, what test to do will again depend on the phenotype, like I said. So at most times we will start with a microarray, look for some losses as we showed you, and if we follow a genetic algorithm, we do the rapid test. If you find an aneuploidy, you do a karyotype. If you don't find an aneuploidy on a rapid test, you will do a microarray. If the microarray is positive and correlates with that phenotype, then you stop there. If it does not correlate with the phenotype, then you either store the DNA or you immediately do a clinical exome, and even go up to, like I said in Katya's case, a whole exome even at 13 weeks with just marked nuchal edema. So you will offer the whole spectrum sequentially, all the tests. And yet, if you don't get a diagnosis, like in our case of Mayer-Gordon syndrome, we store the DNA and offer a postnatal or pediatric evaluation further up. I think you'll agree with me, or if you have anything to add on that, Chitra, you're the best.
Surely. I definitely agree with you. The importance of DNA storage, if they don't continue with the pregnancy, is very, very, very important.
Yeah.
In order to be able to diagnose, to identify the recurrence risk and the inheritance in the next pregnancy. So the other question that we have here is, how much is the recurrence risk in each pregnancy to have fetal abnormalities, or how many percentage of fetus can be normal? So
Yeah, recurrence risk will of course depend whether if it's a chromosomal abnormality, a structural abnormality, you I think have a 1 to 2% recurrence risk. But again, it will depend on the parental karyotype. So if the parents have a similar structural variation in one of them, then the recurrence risk is higher. Just like a Robertsonian translocation, if the parent is a balanced carrier, balanced translocation carrier, then there could be 100% recurrence. So it depends on the particular phenotype. If it's an autosomal recessive condition, autosomal dominant condition, you have a 50% recurrence or a 25% recurrence. So definitely would depend on the phenotype features that you would see on the ultrasound, and of course the previous probands diagnosis. As Chaitra said, you must have a previous probands diagnosis to give a recurrence counseling.
Okay. The other question is, so that is slightly more genetic. It says, please explain NGS, exome sequencing, and Sanger sequencing. So, so would you like to take it, or should
you can go ahead? It's your subject.
Okay. So next generation, so NGS is next generation sequencing. Exome, so whole exome, clinical exome, specific panels, all of this comes under next generation sequencing. So what is the base? Is there is a base assay which constitutes a certain number of genes depending on the panel that we are testing, and the sample DNA that we put into it is going to sequence all of these genes, and then the bioinformatician does an analysis, a specific analysis for these genes, and that's when we understand whether there is a mutation or there is no mutation, depending on what clinical findings we provide the bioinformatician. Sanger sequencing, on the other hand, so NGS panels could contain anywhere between, it depends on the base assay that we are going to use. Sanger sequencing, on the other hand, can be done only for single genes. So say in cystic fibrosis, we want to sequence only CFTR. So if we want to do a full gene sequencing only of CFTR, then we can opt for Sanger sequencing. Or if we have a specific mutation, so like when we looked at the cases for the NGS findings, the mutation in the ALG3, when we saw the glycosylation type 1D, through the NGS testing, we diagnosed the mutation in the ALG3, the homozygous mutation in that particular. To completely repeat the full NGS test, we can only do a Sanger for that specific mutation that we identified in the fetus, or that we identified in the product of conception DNA. So then Sanger sequencing is a targeted sequencing that is done for mutations that are identified through NGS. It is generally mostly used in confirming the parental status of the variation that is identified through NGS in either fetal testing or in a mutation specific test. Whereas NGS and exome sequencing is used when we have unidentified disorders to be able to sequence a number of genes together. So, sir, there's a question for you. Early onset IUGR at 18 to 20 weeks with oligohydramnios, uterine and umbilical artery are high resistance flow, structurally normal, case of uteroplacental insufficiency. Will we tell the patient regarding genetic causes also responsible if they want, or they can go, and can they go ahead with invasive testing?
Okay, so if you have uteroplacental insufficiency identified on the first trimester and second trimester screening, then there's no role of invasive testing. Here, we are very clear that it's a placental insufficiency. If you've got a combined screen risk of, which is high, indicating in high risk of preeclampsia and IUGR, then we will put the patient on aspirin, and not necessarily, we don't need to offer her an invasive diagnosis. We would do a good anomaly scan and follow up with a 24, 26-week scan to look for any missed findings. And the moment you find anything abnormal on the scan, then you will consider. Otherwise, you will not consider an invasive test.
Okay, thank you, sir. There's a question which is, what does karyotyping, microarray, and FISH signify? So, should I?
Yes.
Okay. So karyotyping is done to look for gross chromosomal abnormalities. So whenever we are doing a genetic test, we, like I said, it's very important to identify what the indication is and why we are doing the test. Chromosome or the DNA is measured in something called as base pairs, and the resolution of every test is different. So the resolution of a karyotyping is that it can pick up chromosomal abnormalities caused due to additions, deletions, only for the size of DNA which is higher than 5 million base pairs. So if we are looking at gross chromosomal abnormalities or we want to look for balanced translocations, then we need to do a karyotyping. If we are looking for disorders which could be caused due to deletions and duplications within the DNA, which are much smaller in size, like digeorge or other deletion duplication syndromes, then we have to opt for a microarray. We do a FISH when we want to do a rapid diagnosis in prenatal cases. For the major chromosomal aneuploidies. Also, if we are looking for a particular, so basically if you see an ultrasound finding which is suggestive of digeorge only and you don't want to look at any other deletions, duplications, then you can do FISH for specific microdeletions. Microdeletion FISH are done on cultured metaphases. So their turnaround times are different from the regular major aneuploidies. But whether to do a karyotyping, whether to do a microarray, whether to do a FISH, it will depend on the indication that we're looking at. So
it's all about resolution. Karyotyping is of lower resolution, microarray is
yes,
higher
high
resolution,
resolution.
see much more. And of course, then you target with gene panels, and then you have you look at the entire spectrum of genes with whole exome or clinical exome.
So then there is another question, which is regarding the case, whether if the fetus had other symptoms of Meckel-Gruber syndrome, like polydactyly, occipital encephalocele. It had occipital encephalocele, it had and I mentioned that in the case as well. So the phenotype correlated to the genotype that was found in that case, which is why we went ahead with that. So there's a question which is, if invasive testing comes out as a balanced translocation or a variant of uncertain significance, or if the FISH reports are suggestive of a 22q microdeletion in fetal growth restriction, then how do we counsel the patient? What do we tell the patient?
So the first thing is, of course, the features that you see on ultrasound, whether there is any cardiac defect or if you're dealing with 22q11 microdeletion, then and if the ultrasound features are matching, and then you need to counsel them that this is a major abnormality and probably termination is the best option. What was the other part, the first part of the question?
If there's a balanced translocation with US or...
So if there's a balanced translocation, again, we need to look at the fetus, whether this is going into the fetus as an unbalanced translocation. Just like I said, if it's a Robertsonian translocation, so you have 3 different types of downs. And if you have the Robertsonian in the fetus, and if the parent is a balanced carrier of 21-21 translocation, then there's 100% recurrence, and the patient should not continue or have a pregnancy because there's going to be 100% penetration. So these counseling for recurrence risk is very important from the either from the proband, the parental genotype information, or the fetus, whatever the information that you get. And of course, the ultrasound findings all put together will give us, at the end of the day, we are interested in telling them whether there is a recurrence risk and whether this growth restriction, suppose it's an isolated growth restriction and you find something like a 22q11, then of course you should consider a termination, because this can be, this can manifest with a cardiac abnormality later, or you may not see the cardiac abnormality in a very small fetus on ultrasound, and it may manifest later with a minor cardiac defect.
Thank you. So there's a question which is, how do you choose between high resolution and low resolution microarray?
So Chaitra, you want to answer that?
Yes.
Essentially nowadays we use high resolution microarray, but you could probably answer that.
Sure. The the choice of whether to do a high resolution or a low resolution microarray is essentially based on the clinical findings. Generally, in recurrent pregnancy losses, if we are doing a product of conception testing first trimester, then we are doing testing for ultrasound abnormalities that are seen in a fetus, and in an ongoing pregnancy. It's always better to choose a higher resolution microarray because the coverage is better. We will be able to pick up, genetic anomalies which are caused due to smaller deletions and duplications as well, because there are times that we're not able to identify the smaller deletions and duplications in the low resolution microarray, and cardiac anomalies, intellectual disabilities can be identified through a higher resolution microarrays.
Ultimately, it's all about resolution, and we need the most information today. So it's better to go, even if you don't get information from a high resolution microarray, then you even go on to doing a whole exome sequencing, probably.
Yes, definitely. So we have a question, which is, if the previous pregnancy had gross ultrasound abnormalities, maybe suggestive of FGR, may not. If there is no DNA stored and there is no genetic testing done on the previous pregnancy, and they come basically they come up with their with the second pregnancy, then how do we counsel such patients, and which are the tests that we can offer them? So if you tell me how the patients, how they react to counseling, I can probably reiterate on the testing that can be done.
But I would yet approach it as, because we don't have information from the first, we just have information that there was IUGR. So I would yet treat it as a regular IUGR, do the first trimester combined screening, look for evidence of high risk for preeclampsia, stillbirth, and IUGR. And if there is a Doppler evidence of first trimester screening of high risk, then I would consider it as a case of placental insufficiency. But if there is no risk, no maternal history of APLA or any other condition like that, then I would do first trimester screening, follow up with second trimester ultrasound, look for soft markers. And again, if there is no abnormality, then do a detailed evaluation even after 20 weeks, up to 24 weeks, to look for any additional features. And of course, evaluate for IUGR, because it may not recur again.
Yes.
And if it does recur, then you do additional testing. And if IUGR recurs and you don't have any evidence of preeclampsia or placental insufficiency, then I may consider, with the geneticists corroborating me, an invasive diagnosis.
Sure. Thank you, sir. So we've been asked, will the geneticist will be able to decide or for what we should be doing, a karyotyping or a fish or a microarray, and how do we refer the patient? I think this is a question for me. So basically, if there is a query on which test needs to be done, you can definitely call any one of us, and we will be able to help you out. We will need the clinical findings, a thorough clinical workup, and we will need a family history and consanguinity history. Once we have the information on these things, we definitely needs to be done for a particular patient. So there's a question which is, what is the difference between high resolution and low resolution microarray?
You already answered that.
Yes.
It's about
so yeah, I think that's about it. If there are any more questions, there's a question which is, how useful are apps like Face to Gene? So these are more genetically oriented question, but yeah, if we are able to have the clinical findings entered correctly in an app, or if the proband is available, then an app like Face to Gene can be used. There are a lot of times where probands are not available, index children are not worked up. Actually, in 80% of the cases that come to us, index evaluation is not done. Very few cases index child evaluation has been done. Then, and index child is, if they're deceased, then we're not able to do a workup also once they come in with a second pregnancy. So most of these apps are useful if the patient is available. So somebody's most of the cases which I presented, parental testing was important. So why should the parents with limited budget spend money on testing the aborted? Why not test the parents directly? So if we don't do the index case evaluation, then we don't know that, you know, also with limited budget, it's better to test the index case, because when we do parental testing for this for you know, the same test that we performed on the index case, the cost multiplies by 2 directly. So with limited budget, it's also better to do the index case evaluation right to begin with, because it's one sample that is tested. Also, the index case evaluation is important, very, very, very important, because the index case is affected. Whatever anomalies we are seeing it on the fetal ultrasound, or we are seeing it in the fetus that is aborted. So unless and until the genotype that we have obtained from the results of the test is correlated to the phenotype, we cannot definitely ascertain that this particular phenotype is as a result of this genetic testing or this genetic test result. So unless we do the index case evaluation, we cannot correlate the findings. So index case evaluation is definitely important. Um, what is the difference between QFPCR and FISH?
I think that's a very basic question. Both are rapid tests. They give us information on the basic 5 chromosomal aneuploidies, and the FISH is slightly less accurate than QFPCR. QFPCR slightly more. FISH requires a lot of technical expertise, so you need good laboratory people, whereas QFPCR is automated, and both give results within 2 days. Chaitra, if you want to add anything, I think I prefer
No,
QFPCR
that's,
nowadays.
yes, that's what it is. Sir, there is a question which is, has the time come to move from combined first trimester screening to enhanced first trimester screening?
Uh, so enhanced, you mean multi-gene panel?
With PLGF, yeah.
Yeah, PLGF, yes, of course. If there's a specific history of any like previous history of preeclampsia or anything like that, or I would definitely include PLGF because it gives us more information from the predictive value of preeclampsia and growth restriction. So I would like to add a PLGF at a small extra cost along with the combined screen.
Yes. So there's a question which is DNA storage mandatory in every index pregnancy?
No, not mandatory unless you have an abnormality that you have seen in the previous child, or if there is a family history, or if there is an ultrasound finding which is unexplainable with the current genetic test that you have already done, you will definitely store the DNA then.
Yes. Um, except FGR, no other findings, and array report is likely pathogenic, then how do we counsel the parents?
Okay. So if there is what she means is that if there is an isolated FGR and the array is pathogenic, then there is a problem, because as we know that we can have array abnormalities. So it depends on the size of the abnormality. Then you will definitely do a parental analysis to see whether there is an inheritance from the parent, and definitely counsel accordingly as to the outcome. Because if it's the major gain or loss along with just IUGR, then you could be having a chance of an intellectual disability in the child.
Yes. So how do you interpret biochemical markers in twins or IUGR in one twin or TTTS?
Biochemical markers in twins. See, with twins, we do have a problem because it's a combined risk for both the fetuses you get unless you have an abnormal nuchal that you see on one particular fetus. It's a combined risk that you get, and it can be a problem as to which fetus is affected. And if your combined risk is high, then you may have to test both the fetuses with an invasive diagnosis. So and then you would do in a dichorionic twin, you would offer a CVS in both the fetuses. In a monochorionic fetus, you would offer an amniocentesis. What's the second part of the question?
Sorry?
The second part of the question.
I'll just...
So in multiple pregnancies, there is a
Sir, sorry, if there's an IUGR in twin 1 or TTTS, how do you counsel?
So if the TTTS and selective IUGR are two different entities, so if you have a monochorionic fetus with oligo polyhydramnios sequence with a small fetus, you are probably dealing with TTTS. If you have no polyhydramnios in the recipient and you just have oligohydramnios with a smaller fetus, then you're dealing with selective IUGR. So the counseling is completely different in that particular situation in a monochorionic pregnancy. So if you have a selective IUGR, then that's usually due to a smaller placenta or a cord abnormality, velamentous insertion of the cord, and that could be the reason. So in a monochorionic pregnancy, unless you have any other marker which tells you that there could be a risk of a genetic abnormality, you would consider it as either a vascular cause of TTTS or IUGR in that particular situation.
Thank you. So we'll take one last question. How do we diagnose, how do we suspect rhizopathies apart from raised NT? And when do we decide that a rhizopathy panel needs to be, needs to be opted for in a prenatal case?
So that is very interesting from the ultrasound point of view. If you have a marked nuchal edema more than say 7 millimeter, I would straight away offer a microarray and even a whole exome sequencing or a Noonan's panel, because as you know, Noonan's can lead to very high. So you rule out 45XO, for example. If you've got a large cystic hygroma, the first thing you'll do is a FISH, and you rule out a 45XO or any other aneuploidy, and then straight away go for a microarray. If the microarray is not showing any major gain or loss, then you will offer a Noonan's panel. The second situation would be where the nuchal edema is persistent into the second trimester. Again, you would consider as a Noonan panel again. Or if you see any dysmorphic features like low set ears, you have growth restriction or a small femur, or any other dysmorphic features that you see on the second trimester scan. The other thing that you would consider is also, of course, occasionally if they have a cardiac abnormality. But as I showed you in that flow chart, you may not see a cardiac abnormality even as early as 20 to 24 weeks in a Noonan's fetus. You may see a late manifestation of a pulmonary stenosis. So it basically relies upon a severe persistent nuchal edema, growth restriction that you will see at 20 to 24 weeks. And essentially then if you've got a microarray and a FISH which has not shown any abnormality, the infection screen is normal, you will then consider a Noonan's panel.
So there are two more questions. We'll take them and then we'll stop. There's one question which is genetic and one is for you. One is, why is it important to do Sanger's in parents if mutation is identified? Why not look for that in that mutation in the fetus directly? So like I explained in the cases that I was explaining, there's a possibility that the fetus may have a compound heterozygous or a homozygous condition, or even just a heterozygous in autosomal dominant cases. It's first of all very, very important to understand whether it's a familial mutation or it's a de novo mutation. So that we only be able to diagnose on the basis of the parental testing. Secondly, in compound heterozygous cases, we have to identify whether one mutation is coming from each parent, because only then it's going to be significant. If both the mutations are present on the same allele in the same parent, then it's going to be insignificant and it may not manifest into any genetic disorder in the pregnancies. And then we know that we need to evaluate that particular fetus further, and we cannot only rely on this particular report because the findings are insignificant. So to understand the significance of the finding that we have obtained and to determine the inheritance and the recurrence risk, parental testing is mandatory actually. So one last question for you. Second trimester pregnancy with a normal kidney with IUGR and oligohydramnios with no placental insufficiency, how do we investigate further?
Okay, so if you have second trimester IUGR with oligohydramnios, you will monitor. I would call the fetus back at around 23 to 24 weeks to look for any additional findings that I may have not picked up at the 20-week scan because of the small size of the fetus. And yet again, if we find any additional findings, then of course you would offer invasive diagnosis. But if you don't find any invasive diagnosis, you basically boil down to counseling them because you have not found any risk of first trimester screening for placental insufficiency. But if you've got oligohydramnios and if you've got a bad looking placenta, then, and if at all, I don't know whether biochemical screening has been done, and if you've got a low PAPE or a low alpha fetoprotein, then these could be yet other additional subtle markers that you're dealing with the placental insufficiency. So I would first consider placental insufficiency as the primary factor. And because as you see in about, if you look at FGR, the whole spectrum, 40% or 40 to 50% is yet due to placental insufficiency. And it's only about 20% which is genetic. So I think given a choice, you would first think of a placental insufficiency if you don't have any other additional findings, and specifically if there is oligohydramnios, kidneys are normal, and then you would follow up just like you would follow up any regular fetus with FGR and oligohydramnios, give the cocktail of therapy, which may or may not work in the form of arginine, fluids, etc., better diet, nutrition, counseling. And if things don't work and if the parents do want to evaluate, I think then you have to take the parents into confidence. And if they do want to evaluate, you may consider an invasive diagnosis if they are keen to do it. And also with a genetic counselor in tow with you. So what's most important, I think, from this webinar that we have focused upon is that you need to have good cooperation between the geneticist and the fetal medicine specialist and the ultrasonologist, because you need to have good cooperation to discuss. It's not a one man's purview or one woman's purview. You need to have a collaboration, and then you need to counsel together with the parents and make them understand that what exactly you're dealing with. So I think that is one message that I wish to send forward. Also, the second message why we focused on this webinar was that not all fetal growth restriction is due to placental insufficiency, and we need to keep a genetic cause in mind, because if we think about it, we will look for it. And the third thing is what even Chaitra said very clearly: you need to do very good ultrasound to pick up subtle markers, as we have seen and we have been talking about. And that, I think, is the crux of the matter when we are dealing with FGR.
Thank you. Thank you, sir.
Thank you very much.
Thank you very much for conducting this webinar. And thank you for taking the time out. I would like to thank everybody who attended the webinar as well. Thank you for taking the time out to attend the webinar. Sir, if you have any last...
I think we covered almost everything. Thank you for your cooperation, Chaitra, and lovely cases that you showed. Thank you.
Thank you so much. Thank you, everyone.